with you in kind of an iconographic way the benign conditions for which I believe nuclear medicine can be useful in a child presenting with a musculoskeletal problem. So this is what I have put on the menu for this talk. Of course, infection is the mainstay, what we do in the pediatric setting, at least what I do. Then the chronic recurrent multifocal osteomyelitis, which is somewhat of a misnomer, so that's why I put it separately. The osteochondroses, osteochondritis dissecans, something we see very frequently. Trauma, both accidental and non-accidental, but because it will also be addressed by my colleague, I will not go into much detail for the non-accidental trauma. Sports injuries, low back pain, sickle cell hemoglobinopathy, which is something we see quite often due to the historic connection from Belgium with Africa. And then, of course, a few words on mandibular growth assessment. So let's start right away. So osteomyelitis is usually bacterial in origin. It's most frequent in children below the age of 5, and its spread is hematogenous. So there is a very high predilection for the vascular metaphysis of the long bones. Why? Because this blood flow gets sluggish in the distal metaphyseal vessels. It is usually classified as being acute or subacute or chronic. And then, as I said, chronic recurrent multifocal osteomyelitis is somewhat of a separate disease entity. The diagnosis can be difficult because the presentation is highly variable. Blood tests and radiological imaging findings are often non-specific. However, early treatment is important because it enhances the likelihood of eradicating the infection and limiting complications such as osteonecrosis and growth disturbances. Spread is hematogenous, and pathogens that we frequently encounter are Staphylococcus aureus and beta-hemolytic streptococcus, especially in neonates. And I see that I forgot to add Salmonella species, which we see quite often in sickle cell patients. The physis is a barrier preventing spread of infection from the metaphysis to the epiphysis. However, that is age dependent. So you should be aware that in neonates, transphysial vessels are still patent, and the periosteum is still very loosely adherent. So that means that infection can spread in these patients from the metaphysis through these vessels to the epiphysis or to the adjacent joint. Above 2 years of age, these vessels will have disappeared, and there is a separate blood supply through the epiphyseal artery. And then the physis does act as a barrier protecting the epiphysis. So again, I really love pathophysiology, so I will take you on a brief excursion again on our current understanding of pathophysiology of osteomyelitis, because again, it really highlights the essence of what we see on our images. So I walk you through the cartoon. Basically what happens, why do we see increased bone turnover when there is infection on a bone scan? That's a very valid question, and it's only in the last 5 to 10 years that we actually come to understand how it works. Because the osteoblast, as I showed you, is the major cell that is responsible for bone formation, but it is so much more. In fact, we know it is a cell with immune properties. So when bacteria invade the bone, the osteoblast will sense this. It will sense the products, the proteins and the saccharides that these bacteria produce, so lipopolysaccharide and flagellin will bind to toll-like receptors, and toll-like receptors are in fact receptors of stress. They are emergency receptors. So when the osteoblast detects these products, it will start an entire cascade within the cell, and it will lead to the production of chemoattractants, CCL2, 3-CXCL10. And these products will result in regulatory T cells that will come to the place of the infection. These T cells will bind with the osteoblast, and the osteoblast will present to the T cell using MHC2 these parts of the bacteria it has detected. And this again will result in an explosion of cytokines such as interferon gamma, but also rancor, very interestingly, being produced locally, and that will initiate a cascade of increased bone turnover. So osteoblasts detect these microbial products, secrete chemoattractants, they present the antigen, and this contributes to local inflammation and what we see, the involucrum and sequestration being produced. Unfortunately, it doesn't stop there. What this in fact does is it uncouples bone remodeling, and I will show you how. Because of course, when an osteoblast is invaded or compromised by bacterial products, it will, as a kind of sense, eliminate itself from the environment because it senses something is wrong. And it does that by secreting trail. And trail can bind to the death receptor, and then the cell becomes apoptotic. Now, unfortunately, OPG, which I showed you was a decoy receptor putting the brake on rankle, also binds to trail. Realize that if your OPG is bound to trail, it's gone. So it can no longer bind to rankle. So that means that in the environment of infection, you will have an excess of rankle. An excess of rankle means that you have an excess activation of osteoclasts. And an excess activation of osteoclasts means that you have far more bone destruction than you will have bone creation. So bacteria invade osteoblasts. This induces the trail loop. This will result in a reduction of bone formation because also the osteoblast becomes apoptotic. It no longer produces bone. And you have the excess activation of osteoclasts. So increased bone resorption, decreased bone formation. So far, the excursion into how things work at a cellular level, going back to imaging, what we know, what we love. The power of bone scintigraphy, of course, in osteomyelitis is that we do whole body imaging because we know it can be a multifocal disease, especially in young patients or after septicemia, as illustrated in this older boy, where you can see the pathological sites at the clavicle, the vertebral regions, and the right sacroiliac joint. Again, some very classic signs, both on the blood flow, blood pool images on top, and the late phase images on the bottom, where you see osteomyelitis of the right femur, the left femur, left tibia, and the ankle. However, it can be surprising. Sometimes you can see this bilateral osteomyelitis in this neonate, or an osteomyelitis of the mandible in this adolescent. However, there is some controversy whether bone scan is so good in neonates, and this is old literature. It dates from the early 1980s, where case series were reported that in very young patients aged between 7 and 42 days, the sensitivity of bone scan is miserable, 30%. There was no uptake on blood pool or delayed images. Another 7 cases reported where acute osteomyelitis was missed, bone scan was normal, and finally leading to the conclusion that in this very early and very young patients, a normal bone scan does not exclude osteomyelitis. And that may be due by the fact that the bone scan appearance is variable according to age. And I try to summarize this in this graph where you always have a normal uptake of bone, and it has to be increased to a certain diagnostic threshold before you can call it an osteomyelitis. And then what we hypothesize is that in neonates, the subperiosteal edema and vasospasm or effusion can in fact occlude small blood vessels, leading to a decrease first in uptake before you see an increase. Whereas in older children, this decrease is no longer seen. So that is something to keep in mind. Of course, in the age of hybrid imaging, SPECT-CT, again the question, what is the benefit of adding SPECT-CT to your studies? What I found in the literature should not surprise you. It says that it improves the diagnostic performance of the 3-phase bone scan for osteomyelitis by avoiding false positive or equivocal results. So in fact, it improves your specificity. Nuclear medicine is more than bone scan alone. Additional problem-solving techniques such as the gallium scan, colloid, leukocyte imaging, and FDG PET-CT. And I must admit that FDG PET-CT is a very powerful problem-solving tool in the case of infection in general, and osteomyelitis is no exception. Again, the case I took from the literature showing or illustrating that it can assist you in detecting extraskeletal pockets of infection. So you should consider this in case of clinical failure once an adequate therapy has been tried. And this is an example of a 13-year-old with a multifocal staphylococcus septicemia and multifocal osteomyelitis, where you see that the reason for therapeutic failure was an iliac muscle abscess seen on FDG, which required surgical drainage. But then comes the question, how do we organize the multiple studies that we have available? If you look in the literature, there are guidelines available, and roughly you can summarize them, or I try to summarize them as this. Either you know in a patient who has a suspicion for acute osteomyelitis where the problem is going on, then I believe you should do X-ray first. If that doesn't makes you any wiser, you can move to MRI. And if that doesn't makes you any wiser, or if there is inadequate response to treatment, or if you think, well, this may be multifocal because there is septicemia, then you can do bone scan. However, if you do not know where the site is, then I do believe bone scan still is a valid first-line study or second-line study, if, of course, any other imaging doesn't make you any wiser. So you can do it very early on in the diagnostic process. Then you can also move on to MRI if there are equivocal findings on bone scan, or again, if you believe that there may be extraskeletal involvement, because beware that you do not see that on bone scan. Ultrasound can be useful, in particular for joint effusions, which can then be punctured for diagnosis. So moving away from the osteomyelitis to the septic arthritis, well, the classic findings you all know: you have an increased blood flow and blood pool activity on the affected joint. However, late phase images can routinely show you just diffusely increased periarticular uptake, so not that much to see. And later during the disease, this can then flip to a cold joint, simply because a tense joint effusion can develop, and this may impede the local blood supply to the joint, for instance, a cold hip sign, as we say. Please note that a septic arthritis is indistinguishable from non-infectious causes of an inflammatory arthropathy on bone scan. So just a simple case to illustrate the kind of anomalies you can see on the early imaging phases, but the diffuse uptake you have on late phase. And here, just to show you what a cold hip sign is on the left, you see it on the late phase, but you also see it on the early phase, and ultrasound will confirm you that there is a large effusion in the joint. So, vertebral osteomyelitis and discitis are two separate entities that merit some further detail. And for vertebral osteomyelitis, it is noteworthy that it is less common in neonates and younger children, because they still have a rich network of interosseous collateral arteries and thus a lower chance of septic embolization. The typical pattern on bone scan is increased uptake both early and late. However, I do admit that we have switched largely to MRI in local practice simply because it allows you to assess the soft tissue extension of the infection in a one-stop shop. So that is a kind of study we're performing less frequently these days. So for the discitis, it's the other way around in this one. It's more common in neonates and young children because there are transverse vascular channels through the cartilaginous vertebral end plates terminating just adjacently to this disc space. And these disappear by early adulthood. Bone scan gives a kind of typical pattern where you see increased uptake on blood pool, and the increased uptake is located adjacent to the vertebral bodies. But again, as for the vertebral osteomyelitis, we kind of switch to MR because it is more sensitive than bone scan, and again, it allows exquisite visualization of adjacent soft tissues and any collections that may have formed. So, moving then to the chronic recurrent multifocal osteomyelitis. It is an inflammatory bone disease, and we actually don't know quite well why it happens. It is characterized by a sterile osteomyelitis. It in particular affects children between the age of 7 and 14, and it tends to do so more in girls than in boys. It is episodic with episodes of self-limiting pain and swelling, X-rays usually show an osteolytic change that later becomes partly sclerotic. It's typically multifocal. Changes tend to be symmetric. Differential diagnosis, of course, is that of infectious osteomyelitis, malignancy, and arthritis. For the adults, there is some overlap with the Sappho syndrome, but you don't really, you only rarely see the skin manifestations in children. It remains a diagnosis of exclusion, and that is why imaging is important, because you have to exclude all the other possible causes of the symptoms of the patient. So, as I said, the mechanism is not that clear. There's no evidence of microbial etiology, either by culture or PCR. Antibiotic therapy does not really alter the disease course. There is an association with autoimmune diseases, as listed here, and recently there has been a gene mutation reported in the LPN2 and the interleukin-1 receptor, so maybe that is can be a possible cause for this entity. The treatment is very various, but basically these are all immunomodulatory drugs that can be used, so that is what they have in common. So the X-ray finding, as I said, initially osteolytic and surrounding sclerosis developing over time. There can be diffuse hyperostosis or a periosteal reaction. However, what you do not see are the typical signs of pyogenic osteomyelitis. So there is no periosteal elevation, no sequestration, neither do you see abscesses or sinus tracts. However, some lesion of this can be occult on radiographs, and that is, of course, why bone scan is useful, because the disease is multifocal. In fact, it's part of the definition. And bone scan can detect these clinically or radiographically silent lesions. Literature data is very convincing. Bone scan has a 96% sensitivity for symptomatic and occult lesions. The early phase typically shows hyperemia or blood pool. Can be useful to detect those lesions that are close to the metaphyseal areas, because they can be somewhat difficult to interpret on late phase imaging. But also late phase imaging typically should show you an increased uptake that is focal. Growth plate involvement may appear as a widened or blurred in the initial or late phase imaging, and a technique can be useful to select the site of biopsy, and you can also monitor treatment, as you would expect that these lesions decrease during therapy. So an example of a 13-year-old with left knee pain, where you can see the mixed lytic sclerotic lesion on plain X-ray, and you can also see the diffuse changes in the bone marrow on the T2 imaging on MRI. To show you what bone scan image gives you in the early phase and the late phase, and do note the bilateral involvement of the distal femur. And this is another case of a patient with CRMO, but this time involving the distal tibia bilaterally. So it is a diagnosis of exclusion, but you should think of it in case of recurrent, prolonged course of recurrent episodes, involvement of multiple sites, especially the lower extremities, a predilection for the metaphysis. Lesions tend to be symmetrical, involvement of locations that are uncommon for usual hematogenous osteomyelitis, such as the clavicle. Again, you do not really see the changes you would expect to see with longer existing osteomyelitis, so no abscesses, fistula, and so on. Cultures are negative, or association with autoinflammatory disease, and it improves with non-steroidal anti-inflammatory drugs, but it does not respond to antibiotics. Okay, so moving to the osteochondrosis, this is somewhat of a different disease. It means a pathological process of the epiphyseal or physeal bone growth, and the etiology is not quite clear, and it likely involves avascular necrosis caused by trauma, steroids, genetic factors, and so on. There are many different eponyms out there, depending on the skeletal site, but in fact it's just a variation of the same disease entity. Most common occurring is Perthes disease in the femoral head, but Sever's disease at the calcaneus is something you see sometimes as well, as is the Osgood-Schlatter disease of the tibial tubercle. So bone scan is useful in identifying these sites. It can occur at multiple different locations. Well, it is interesting that the scintigraphic changes occur before the X-ray becomes abnormal, so that is a strength of our study. And bone scan is both very sensitive and highly specific just because of the typical patterns at which it occurs. So an example of a 19-year-old female with an Osgood-Schlatter disease, where you can see the hot spots at the tibial tubercle, both on the bone scan and the appearance of the lesion on X-ray later on in the disease. So Perthes disease, as I told you, is the most common avascular necrosis condition in childhood, and it often has an insidious and subtle symptoms. Traditional pinhole imaging is very useful in diagnosing and prognosticating these lesions. The scintigraphic revascularization early in the disease process predicts the more rapid formation of new bone, and a classification system exists, which I will show you later on. As you can expect, early in the ischemic phase, bone scan shows reduced vascularity and a photopenic area on the delayed images. Later on, when revascularization has started, there is increased uptake both early and late phase. So this is the famous Conway system. Stage 1, you have a total avascularity of the femoral epiphysis, and then things can go both ways. You either develop a pathway A, which shows a lateral column, and revascularization starts from the lateral column and moves medially. This is a good prognosis. Or you go stage pathway B, where you can see that revascularization starts from the medial part, and this is associated with a less favorable outcome. Recently, we've also started doing SPECT-CT later in the disease course to see if it can add information on treatment decision, in particular in those patients who have developed or followed the B pathway. But again, a little bit too early to say if we become any wiser out of it. So osteochondritis dissecans, what is it? Well, it's, as you know, an aseptic separation of an osteochondral fragment with gradual fragmentation of the articular surface. And the majority of cases are between 10 to 40 years of age, so it's not strictly pediatric. There is a 2-to-1 male preponderance, and the symptoms are variable and can range from being nearly asymptomatic to significant pain in locking, and locking, of course, is suggestive of a loose body. Joint effusion and synovitis are typically present. Again, the etiology is uncertain, but we think there is a role for trauma, avascular necrosis, emboli, and genetic factors. And typically, what I see most frequently, it involves the knee, and to a lesser extent, the ankle and the elbow. And SPECT-CT really has become a game changer for this condition, simply because it has dramatically increased our specificity. Well, the lesion is typically limited to the articular epiphysis, and you can see it most of the time at a convex surface. And this is a patient presenting with left ankle pain, where you see the hot spot on the planar, on the early and the delayed phase imaging, but it is only if you do the SPECT-CT that you can now really call the lesion what it is and not mistake it for something else. Another example of an OD lesion of the right femur, where you can clearly see the lesion demarcated on the CT part associated with the hotspot on bone scan. So trauma, well, again, my love for pathophysiology will show, because fracture healing, again, is something that we know very well clinically, but we did not know really at a molecular or cellular level what was involved. And it is important because fracture is the most common large organ traumatic injury in humans, and they usually tend to heal quite well, but 10% does not. And fracture healing, most of the time, is one of the few postnatal processes that is truly regenerative, meaning not associated with scar tissue formation. So bone is restored to its pre-injury cellular composition, structure and function, and all morphogenetic pathways that are active during the embryonic skeletal development are expressed during healing. But what we have come to appreciate over the past 5 years is the enormous importance of the immune system in the healing of fractures. And again, some cartoons to show you this. So remember, in the previous talk when I addressed the embryonic bone formation, the endochondral and membranous pathways. So what happens just hours after a fracture is that you have the first of 3 stages. And the first stage is the inflammatory stage. And you have a massive influx of immune cells, and these immune cells will try to clear up all the dead material, the necrotic tissue, and they will start the process of repair, and they do that by promoting cytokines that will promote angiogenesis and tissue repair. And this is an anabolic phase, so it means that the bone gains volume and the tissue mass increases. And that is because the influx of stem cells and local mediators. But what we now also understand is that the immune system at that point becomes immune suppressive. So you get an influx of T regulatory cells and they will suppress the immune system. And why do they do that? Simply because they want to protect the callus. Callus formation, what we know from imaging, is crucial to have normal bone healing. But you don't want callus removed as being, it should not be there, and the immune system clears it up. So the immune system needs to be suppressed in order for normal callus formation and chondrocytes and cartilage formation to occur. So the second step is the enchondral stage, where the cells that are there will start producing bone along an edge of a cartilaginous callus that is formed. There will be a very important vascular bed that provides all the nutrients to the site of fracture in order to promote healing, and then slowly mineralization will start to occur. And at the end of the enchondral stage, you will see that chondrocytes will become mature, and they usually tend to become apoptotic at that time as well. And that is really the end of the anabolic phase. And then finally, what we need is to clear up the skeleton, or indeed the scaffold that has been created to promote healing. So the last phase is coupled remodeling, and it's catabolic. What it really means is that we have to remove the callus that has been formed. So secondary bone formation will continue, and it will be coupled cycles of osteoblast and osteoclast activity, so in order to restore the initial cortical structure. And again, Rankel has been shown to be pivotal. The marrow space is re-established and the vascular bed then regresses. So that is what happens in normal circumstances, which of course explains to you why we see increased bone turnover on bone scintigraphy after trauma. And still one of the most useful indications, I believe, is a Toddler's fracture. And this is usually a spiral or oblique fracture of the distal tibia in a child. And most of the time it just presents with a refusal to walk or with a limp. More often than not, the trauma has already been forgotten that caused it. It can be seen on plain radiography sometimes, but more often radiography is normal. What you see on bone scan is increased vascularity early on, and the delayed images can show you this typical spiral line, some focal uptake, or just a diffuse increased uptake. Again, most common site is the tibia, but to a lesser extent other skeletal sites can be affected too. So just a classic example of a 19-month-old boy who presented with an inability to bear weight. There was swelling, redness, and point tenderness of the right tibia. The uptake on bone scan extended beyond the metaphysis into the physis, and that was why the diagnosis of a Toddler's fracture was preferred rather than osteomyelitis. And this is a typical spiral lesion in a 2.5-year-old boy where the fall from the bed was 2 weeks prior, and x-rays that were performed were normal. So non-accidental injury, unfortunately, is something that happens too much. So physical injury, of course, causes skeletal stress remodeling reactions and fractures. And in non-accidental injury, there has been extensive research into the exact mechanisms on how these injuries come about. And they're usually multifocal, and that is why bone scan is such an important complementary tool, with being its bone scan or sodium fluoride PET-CT as discussed previously. So there has been identification of some lesions that are highly specific, such as metaphyseal lesions, posterior rib fractures, scapular fractures, spinous process fractures. Please note that these are fractures that are very uncommon to have in just an accidental way. So just an example of a bone scan image in a 4-month-old boy, where you can clearly see the posterior rib fractures, but also note the asymmetry of the skull and the left parietal bone. This was also found to be a fracture. So I will not go into the additional value of sodium fluoride PET-CT because I believe that will be addressed by the next speaker. So, but I do believe that sodium fluoride PET-CT has a major role to play in non-accidental injury. So sports injuries is an increasing part of our daily clinical routine. It most frequently includes elbow, shoulder, hip disorders, back pain, and concussions. Children are more susceptible to injury because they have decreased coordination, open physis, and still growing. It was interesting to see in one paper that elbow pain in baseball players, it was an American paper, is as frequent as 70%. So usually it tends to be fatigue or stress-related injuries, and these are more common in the 6 to 18-year-old children, even more common than the acute injuries. Mechanisms include lack of proper technique, they need more core strengthening, neuromuscular conditioning, and appropriate time for rest in order to reduce the incidence of sports injuries. It is the most commonly caused by overtraining or overuse. And this, overuse then leads to repetitive exertion without taking too much rest. Is in fact the major risk factor. However, the pressure that is sometimes put on these youngsters, in particular when they are in professional training, is sometimes really, really high, and they simply don't want to rest because they fear they will lag behind on their colleagues. So radiographs are, of course, or often the first imaging study that is obtained, but usually they do not contribute so much as these lesions tend to be occult. And that is, of course, where bone scintigraphy comes in. Blood pool can help you to demonstrate soft tissue injury, but with SPECT-CT you can also very well assess tendons. Late phase can help you to identify fractures as early as 72 hours after onset. Again, if it is radiographically occult or you suspect multifocal disease, bone scan is the way to go. And this is illustrated beautifully. In this case, it's a 16-year-old runner who has in his lower limbs an entire collection of stress-related injuries. You can see a stress fracture of the metatarsal, you can see a stress reaction in the navicular, you can see a stress reaction in a sesamoid, and you can also see a shin splints or a medial tibial stress syndrome, all in one patient. So osteostress at muscle insertion sites is also common, and I've listed them here, but I will not go into too much detail. In a recent comparison of bone scan with MRI in 28 patients, it was noted that skeletal scintigraphy was slightly more sensitive and had a higher negative predictive value than MRI. However, it should not surprise you that MRI was slightly more specific in calling the diagnosis of these stress injuries. However, the gain in sensitivity was higher than the loss in specificity. So just some illustrations. A patient with an Achilles tendonitis and a plantar fasciitis, beautifully seen on bone scan. But as I told you, with this advent of SPECT-CT, you can now also appreciate better what we saw on early imaging, in particular for tendonitis. And this is an example of a tibialis posterior tendonitis, which you see commonly in dancers and gymnasts. So this increased uptake tends to signal inflammation. I can show you there. But it's pity that I didn't show you the axial slice, because on the transaxial slice you can now also really see the tendon and how it's thickened compared to the contralateral side. So that is important to look at the soft tissue of your SPECT-CT as well. This one I already showed you. It's an accessory navicular, but in young patients who do intensive sports, this can be symptomatic. And here you see the lateral syndrome, the lateral analog of the tibialis posterior, which is the peroneus brevis tendonitis. And here again you can see how the hotspot will not only project to the bone, but you can also appreciate the enlarging of the thickening of the tendon. Shin splints, a very common medial tibial stress syndrome. You all know it. It's exercise-induced pain due to the posterior medial aspect of the distal two-thirds of the tibia. It's caused by an inflammation of the crural fascia and increased bony metabolism with vascular ingrowth. Triple face, you know, of course, the pattern. Low-grade linear patchy uptake of tracer along the posterior tibial cortex under the late phase images only. Be careful, blood flow images can be normal. Personally, I've not yet identified any use of SPECT-CT, so we still manage to do this with planar imaging. It is important to differentiate stress fractures from shin splints because the management is different. If there is stress fracture, then the patient has to be avoid exercise for a number of weeks because there is a risk of a complete fracture, whereas when it is just uncomplicated shin splints, then exercise can continue as long as they feel comfortable. So facet joint stress is also very common, and what you see most is the L5 level. And most of affected sports are very much ballet, which I see very frequently because we have a Royal Ballet School where I work in the city. Football and cricket I see less frequently. And it's important because it can lead to spondylolysis and subsequently spondylolisthesis. And again, these are not typically detected radiographically, and MRI is not so helpful either. SPECT-CT has been a game changer for us because it allows us to assess spondylolysis and spondylolisthesis and not only say whether there is a hotspot, yes or no. So an example in a 15-year-old ballet dancer with chronic low back pain where you see the hotspot in the facet joint on the right, but you can now also see that there is lysis of the interarticular part, so this is a spondylolysis. And even in children who do not exercise or do not do high-level exercise or sporting, low back pain is common. And this was a particular interesting paper of some time ago. It was a retrospective analysis of patients between the ages of 2 and 18 years, and what we the exclusion criteria was that there was no night pain or constitutional symptoms to rule out, well, those with probably more serious disease. And what the authors tried to do was differentiate between what was called mechanical pain, so something that we did not find a cause to treat, versus those that was organic or termed organic, that is, there was an actionable disorder for the low back pain. And neither demographics or physical findings could differentiate between mechanical or organic back pain. They did a combined cost efficiency analysis, and the results briefly are that when pain is rather acute, so less than 6 weeks, bone SPECT did better compared to MRI. And if pain was persisting for more than 6 weeks, then MRI was said to be more the better choice. Now, 2 remarks: this should not surprise us, because it takes time before something becomes visible on anatomical imaging, so I'm not surprised that you need 6 weeks before MRI becomes useful. Second remark, this was SPECT only, so no SPECT-CT. Okay, some anatomical variants that may be causing some issues. First of all, the Bertolotti syndrome. It can be a cause of pain. It's a form of lumbago in the lumbosacral transitional vertebra, and this is common. You see it in 5% of patients, but it can be a cause of back pain in younger patients, and you can really assess it very nicely with SPECT-CT. So this is an example of a right lumbar 5 transitional vertebra with increased uptake in the pseudo joint. So this in a girl who presented with chronic low back pain. And this is another example in an 18-year-old who presented with low back pain, and again you can see the transitional vertebra very nicely on the CT part and the increased uptake in the joint on the SPECT part. So a few words on the sickle cell hemoglobinopathy. Well, it's a hereditary hemoglobinopathy, and the changes in the deoxygenated hemoglobin S results in erythrocyte rigidity and fragility. And therefore, these people are at increased risk of infection, in particular Salmonella species, and avascular necrosis caused by vascular occlusion because these erythrocytes become rigid and fragile. However, please note that bone infarction is the vast cause of pain, so it's much more frequent than infection, and the ratio is probably 50:1. It is important to differentiate between osteomyelitis and bone infection. However, it's very challenging because both can present with fever and leukocytosis, and radiographs are normal or show only soft tissue swelling, and both can evolve to bone destruction and periosteal reaction. So while bone scan is useful to try to identify an occlusive crisis, it does not reliably distinguish osteomyelitis from bone infarction. In the acute phase, you see decreased uptake, and later on, 3 of 7 days after the onset of symptoms, uptake becomes increased. If early in the course of symptoms there is increased tracer delivery and uptake, this is more suggestive of osteomyelitis, obviously, because you can then you fail to see the occlusive, the ischemic part. It's usually you see multiple sites of abnormal uptake, and usually you see in a combination of acute lesions where you see photopenic defects combined with older lesions that will show inhomogeneous uptake. What is typical in these patients is that you see the spleen, and this is most of the time caused by previous splenic infarctions, and the kidneys can be very prominent as well due to altered iron distribution because they often receive transfusion. So what about other imaging techniques? Leukoscan, unfortunately, is not really reliable in discriminating between a vaso-occlusive crisis and osteomyelitis. If you still use gallium, you can see intense uptake when there is osteomyelitis. While if it is decreased or absent, then that tends to be more specific for infarction. Marrow scintigraphy, FDG, PET, CT, the data are out there. MRI, unfortunately, the marrow intensity signal of the T1 images is not a reliable criterion either to differentiate bone infarcts from osteomyelitis in children. So again, usually this means that we do multiple techniques to come to a working diagnosis or differential diagnosis. So an example of
5 minutes.
Yes, I'm nearly done. Thank you. One example of a sickle cell patient where I just wanted to show you the typical uptake of the spleen, but also note that there is a photopenic defect in the left hip, signaling an acute crisis. And please also note the diffuse heterogeneous uptake in the long bones and the skull, which is evidence of earlier crises. Again, increased uptake in the spleen. A 9-year-old girl with a sickle cell crisis and acute right hip pain, where you can very well see the reason for the acute hip pain. Here you see the bone infarct, but please also note that there is a history of things in the skeleton. You see the lumbar vertebra are abnormal, and what's also asymmetric is the iliac crest here, so this is probably a bone infarction as well. As I said, you usually see many things going on at the same time, so a combination of acute and older lesions. Again, photopenic area is a bone infarct. Please also note the increased uptake at the other sites. Spleen increased uptake as well. This is probably an earlier event going on, now becoming visible as a hotspot. And if you look at the MRI images, it's sometimes really scary. So, to conclude my talk, the mandibular growth assessment. Abnormalities in mandibular growth obviously can cause facial deformity, and this asymmetry can be congenital or acquired. And you either have overgrowth or undergrowth, and that is where bone scan comes in. So the unilateral condylar hyperplasia is the most common overgrowth asymmetry, and it can also be caused by trauma, tumors, or fibrous dysplasia. Undergrowth, on the other hand, can result by trauma, radiation, inflammatory joint disease, or hemifacial microsomia. What is important to the clinician is to determine which is the normal site and which is the abnormal site, and to determine if asymmetric growth pattern is progressive, that means it's still active, or it has become quiescent and is now stable. So for the unilateral condylar hyperplasia, hyperactivity is seen within the mandibular condyle when it is active. You get a deviation of the chin to one side. You can get occlusional disturbances, and also it can lead to degenerative changes in the temporomandibular joint. So if the condyle is inactive, then the mandibular asymmetry can be treated by conventional reconstructive surgery to align the mandible and correct occlusion, and this spares the patient of an open joint operation. However, if the condyle is still active, then you need to perform this surgery. You need to do a high partial condylectomy to arrest growth, because otherwise the disease will simply, or the malformation will simply return after you have performed the orthokinetic surgery. So in my last slide, to just give you an example, the ratios has been published. The cutoff is 55% left to right. So what you see here is a patient with deviation of the chin to the left-hand side, and you see that apologies, it is caused by a hyperactivity on the right-hand side. You can see the increased uptake compared to the left on the SPECT, but what you can also nicely see on the SPECT CT is the hyperplasia of the condyle, which I see this one is much wider than the normal side. So that concludes my talk. Thank you.